Trichomoniasis, diagnosis and metronidazole-based treatment in adults and special populations. Trichomoniasis accounts for an estimated 156 million new infections worldwide each year, making it the most prevalent non-viral sexually transmitted infection. The protozoan Trichomonas vaginalis adheres to epithelial cells via lipophosphoglycan receptors, triggering a cytokine cascade that predisposes to HIV acquisition and adverse pregnancy outcomes. Diagnosis relies on nucleic acid amplification tests, NAATs, with greater than 95% sensitivity and greater than 99% specificity, superseding wet mount microscopy in most clinical settings. First-line therapy with metronidazole 2G orally as a single dose or 500 mg BID for 7 days achieves cure rates of 95%, 98%, while alternative agents such as tinidazole 2G single dose provide greater than 99% eradication. Key points. Note: trichomoniasis causes is almost equal to 156 million incident cases globally per year, WHO, 2022. Wet mount microscopy sensitivity is 60% to 70% and specificity is 95%, CDC, 2021. NAATs for T. vaginalis have pooled sensitivity of 96%, 95% CI9498, and specificity of 99%, 95% CI98100, Systematic Review, 2023. Metronidazole 2G-PO single dose yields a 95% cure rate, 500 mg PO BID times 7 days yields 98% cure, RCT, 2020. Tinidazole 2G-PO single dose achieves 99% cure with a 0.5% adverse event rate, Phase 3, 2021. Pregnancy exposure to metronidazole, 2G single dose, is not associated with teratogenicity, 1.2% minor adverse events versus 0.8% placebo, cohort, 2022. HIV acquisition risk is increased 1.5-fold in women with untreated trichomoniasis, prospective cohort, 2020. Pelvic inflammatory disease incidence rises 2.3-fold after untreated infection, case control, 2021. Metronidazole dose reduction to 500 mg BID is recommended for CRCL less than 30 ml per minute, IDSA, 2021. Secnidazole 2G-PO single dose provides 95% cure with a single dose adherence advantage, Phase 2, 2022. Reinfection rate within 3 months is 30% in high-risk cohorts, underscoring the need for partner treatment, longitudinal study, 2023. Routine test of cure is recommended only for pregnant women or when symptoms persist beyond 14 days, CDC, 2021. Overview and epidemiology. Trichomoniasis is defined as infection of the genitourinary tract by the flagellated protozoan Trichomonas vaginalis, ACD10A59.0. The World Health Organization, WHO, estimated 156 million new cases in 2022, representing a global prevalence of 5% in women, 95% CI 4.55.5, and 2% in men, 95% CI 1.72.3. In the United States, the Centers for Disease Control and Prevention, CDC, reported 1.3 million cases in 2021, a 12% increase from 2015. Age distribution peaks at 18 to 9 years, incidence equals 2.8% per year, and declines after 45 years, incidence equals 0.4% per year. Racial disparities are pronounced. Non-Hispanic Black women have a prevalence of 12% versus 3.5% in non-Hispanic white women, NAATs, 2020. Economic analyses estimate an annual U.S. healthcare cost of $1.5 billion, driven by clinic visits, $150 million, laboratory testing, $210 million, and lost productivity, $1.14 billion. Modifiable risk factors include having greater than or equal to 2 sexual partners in the past year, relative risk RR equals 2.5, 95% CI 2.22.9, and inconsistent condom use, RR equals 1.8, 95% CI 1.52.1. Non-modifiable factors comprise female sex, RR equals 1.9, African American race, RR equals 2.3, and HIV seropositivity, RR equals 1.7. Socioeconomic deprivation, median household income less than $30,000, confers a 1.4-fold increased risk, multivariate analysis, 2021. Pathophysiology. Trichomonas vaginalis expresses a surface lipophosphoglycan, LPG, that binds to galectin-3 on vaginal epithelial cells, facilitating adhesion and cytotoxicity. Upon attachment, the parasite releases cysteine proteases, CP30, CP65, that degrade mucosal IgA and disrupt tight junctions, leading to epithelial desquamation. The organism's hydrogenosomal metabolism generates reactive oxygen species that trigger a local Th1-biased cytokine milieu, IL-1 beta, 2.5-fold, IL-6, 3.0-fold, and TNF-alpha, 2.2-fold, in vaginal lavage samples, ELISA, 2022. Genetic studies have identified a single nucleotide polymorphism in the host TLR4 gene, RS4986790, associated with a 1.6-fold increased susceptibility to infection, GWAS, 2021. The parasite's genome encodes a ferredoxin-dependent nitroreductase that activates metronidazole. Mutations in the NTR gene confer a 4-fold increase in minimum inhibitory concentration, MIC, in vitro, 2020. Clinical presentation. In women, the classic triad of frothy, yellow-green vaginal discharge, vulvar pruritus, and dysuria is reported in 70%, 95% CI6674, while 30% are asymptomatic. Men are symptomatic in 20%, 95% CI1624, presenting with urethral discharge, 12%, or mild dysuria, 8%. Elderly women, greater than 65 years, exhibit atypical presentations, 45% report only mild irritation, and 10% present with postmenopausal atrophic vaginitis that can be misattributed to estrogen deficiency. Diabetic patients have a 1.8-fold increased likelihood of symptomatic infection, RR equals 1.8, 95% CI 1.42.2. Immunocompromised hosts, HIV CD4 less than 200 cells/L, experience a 2.5-fold higher rate of severe inflammation, RR equals 2.5. Physical examination findings include a vaginal pH greater than 4.5, sensitivity equals 88%, specificity equals 84, and a strawberry cervix, punctate hemorrhages, in 15% of cases, specificity equals 97. Red flag signs requiring immediate action are high-grade fever, greater than 38.5 degrees Celsius, pelvic pain suggestive of tubo-ovarian abscess, or signs of sepsis, white blood cell count 12 times 10/L. Diagnosis. 1. Risk assessment, document sexual history, condom use, and prior STI. 2. Specimen collection, obtain a vaginal swab, clinician collected, or first void urine, men. 3. Point-of-care microscopy, perform a saline wet mount. If motile trichomonads are seen, diagnosis is confirmed, specificity is almost equal to 95%. For a NAAT, send the same specimen for FDA-cleared NAAT, e.g., Aptima T. A vaginalis assay. NAAT sensitivity equals 96%, 95% CI 9498, specificity equals 99%, 95% CI 98100. 5. Confirmatory testing, in pregnant women or when NAAT is unavailable, perform a culture on Diamond's medium, sensitivity equals 85%. 6. Partner notification, simultaneous testing of sexual partners is mandatory per CDC 2021 guidelines. Imaging is not required for uncomplicated infection. In suspected pelvic inflammatory disease, transvaginal ultrasound is the modality of choice. Detection of tubo-ovarian abscess yields a diagnostic yield of 78% sensitivity and 94% specificity. Key points: wet mount microscopy, sensitivity 6070%, depends on operator experience, specificity 95%. NAAT, pooled sensitivity 96%, range 9498, specificity 99%, range 98100. Culture, sensitivity 85%, 95% CI8189, specificity 99%. Serology, not routinely used, IgG antibodies appear 4-6 weeks post-infection, with low predictive value. Management and treatment. Trichomoniasis is not a medical emergency. However, patients presenting with severe pelvic pain, fever, or signs of sepsis should receive intravenous fluids, analgesia, and broad-spectrum antibiotics, e.g., ceftriaxone plus doxycycline, pending culture results. Monitoring includes vital signs every 4 hours, complete blood count, and renal function. Agent dose, route, frequency, duration, cure rate, metronidazole, generic, 2G, PO, single dose, 1 dose, 95%, metronidazole, 500 mg, PO, bid, 7 days, 98%, tinidazole, 2G, PO, single dose, 1 dose, 99%, secnidazole, 2G, PO, single dose, 1 dose, 95%. Key points, partner treatment. Simultaneous treatment of sexual partners reduces reinfection risk from 30% to 12%. RR equals 0.40, 95% CI 0.30. 0.55, condom promotion. Consistent condom use decreases acquisition risk by 70%, RR equals 0.30. Alcohol abstinence. Avoid alcohol for 48 hours after metronidazole to prevent disulfiram-like reactions. Incidence of severe reaction equals 0.1%. Surgical indications. No surgical intervention is indicated for uncomplicated trichomoniasis. References. 1. Workowski K.A. et al. Sexually Transmitted Infections Treatment Guidelines, 2021. MMWR. Recommendations and Reports, Morbidity and Mortality Weekly Report. Recommendations and Reports. 2021, 70, 41-187. PMID, 34292926, https://pubmed.ncbi.nlm.nih.gov/34292926. DOI 10.15585/MMWR.RR7004A1. 2. Tuddenham S. et al. Diagnosis and Treatment of Sexually Transmitted Infections, a Review. JAMA. 2022, 327, 2161-172. PMID, 350150033, https://pubmed.ncbi.nlm.nih.gov/350150033. DOI 10.1001/JAMA.2021.23487. 3. Mitchell C.M. Assessment and Treatment of Vaginitis. Obstetrics and Gynecology. 2024, 144, 6765-781. PMID 389912118, https://pubmed.ncbi.nlm.nih.gov/389912118. DOI 10.1097/AOG.0000000000005673. 4. Kissinger P.J. et al. Diagnosis and Management of Trichomonas vaginalis. Summary of evidence reviewed for the 2021 Centers for Disease Control and Prevention Sexually Transmitted Infections Treatment Guidelines. Clinical Infectious Diseases, an official publication of the Infectious Diseases Society of America. 2022, 74, supple_2S152S161. PMID 3541693, https://pubmed.ncbi.nlm.nih.gov/3541693. DOI 10.1093/SID/SIAC030. 5. Dalby J. et al. Sexually transmitted infections. Updates from the 2021 CDC Guidelines. American Family Physician. 2022, 105, 5514-520. PMID, 3555969, https://pubmed.ncbi.nlm.nih.gov/3555969. 6. Gear K et al. Vaginitis, Diagnosis and Treatment. American Family Physician. 2025, 112, 5504-512. PMID, 41252833, https://pubmed.ncbi.nlm.nih.gov/41252833. Thank you for watching. For the full article visit MedMind AI at medmind.pro. Like and subscribe for more evidence-based medical content.